just in that. Or you can use the mouse and it'll click. But there's, I think, are you just in the...
I'm only saying a few words, so I don't need it when you forget.
Right, I think there's a because she's after you. Yes, well, there is a slide for Robert, so if you go through a couple, you'll see Robert.
Okay, we're ready to make a start. Can everybody hear me? Yes, it's clear. My name's Marie Seaton. I'm the independent chair of the Buckinghamshire Safeguarding Adult Board. And I'd like to welcome you all today. I think it's a particular achievement the day after a bank holiday, half term and floods in various parts of the county. So welcome to everyone to the day. First of all, the housekeeping rules. The toilets, if you haven't already found them, are past the cafe on the right-hand side. Fire procedures, there's no fire alarm expected, but if there is a fire alarm, everyone needs to go out that right-hand door, or if you have a disability, the left-hand door. There will be a break for coffee and lunch is provided, and that will be outside. We're aiming to finish round about 4:15. Could I ask that mobile devices are on silent or vibrate, because that really helps speakers. And obviously there's no smoking, so our colleagues will be very pleased about that. So in terms of today, it's very much an opportunity for professional reflection, very much about learning, having discussions together in the context of what do we understand about self-neglect, what is our awareness of self-neglect, and what does it mean in terms of our practice, and what does it mean in terms of organisations and organisations' responses. So it's an opportunity to debate, to ask lots of questions, not to feel that, oh, I should know everything about self-neglect, because it is one of those areas within the Care Act and in safeguarding that is a challenge for many of us in terms of understanding it both in terms of individuals and what it means, and in terms of organisations and how organisations respond. So in terms of, you will be aware from the two Safeguarding Adult Review case studies that you have that the Buckinghamshire Safeguarding Adult Board commissioned two Safeguarding Adult Reviews during 2017. The board approached it very much in terms of we need to learn from what happened in these two individual circumstances. And you can tell from the case studies that there is no particular set of circumstances when self-neglect occurs. With those two cases, the individuals were very different, both in terms of age, culture, ethnicity, in terms of their needs, whether they had contact with services, whether they were willing to have contact with services. So I think there can be a tendency for some people to think that self-neglect is about an older person who lives alone and hoards their belongings. And you'll hear from these sessions and the speakers today that actually circumstances vary significantly. And in terms of the definition of self-neglect, we know that in terms of individual, it can be self-neglect in terms of personal care, in terms of their health, in terms of any contacts with other networks, friends, communities, in terms of nutrition and hydration as well. In terms of their environment, as you'll hear from our fire colleagues, it can be about significant hoarding, and you will see from the packs there are photographs of hoarding that reaches such a risk stage that it means there has to be interventions if possible. It also means, in terms of the environment, there can be significant squalor and infestation. So again, there's not one set of circumstances, but alongside those circumstances, it's when there is risk to one's health, safety and well-being, and also when an individual is reluctant to actually accept any support or services that may be available. So complex and challenging for all of us. So today is an opportunity to explore the toolkits that are available that is very much about, do they help and support you in your practice? Because that's the essence of today. It's about how do I respond as a professional when there are significant challenges, and many case studies, case reviews, of which there's about 49,000 safeguarding adult reviews across the country, where self-neglect was a significant feature. And in those cases, there were often issues like a lack of leadership and coordination, difficulties in assessments, with a mental capacity assessment, mental health assessments. The one that always crops up, the challenges of communication and information sharing across the whole system. And alongside that, many of those reviews found that agencies were actually working on parallel lines without actually communicating or sharing information with each other. Those reviews also found that often there could be not enough understanding of legal duties and powers, certainly not enough understanding of the Mental Capacity Act. So you'll see from the programme today, we have a series of speakers, a lot of expertise, so we'll be sharing that, and it's an opportunity to ask questions as the day goes on. The first two speakers are very well known in their fields. Robert Lake led one of the safeguarding adult reviews within Buckinghamshire. Mary Buckman, many of you may well know from Mental Health Services. So they will be taking us through the two cases. And then we'll have our fire colleagues, which is always good, because I don't know about you, but I always find presentations by our fire colleagues really uplifting, because they're very practically based. So you'll have two speakers, then a very practically based presentation, and then coffee break, and then we'll move into Mental Health Act and Mental Health Assessment and the Mental Capacity Act. So from today, it's very much what you take away in terms of feeling that you've increased your understanding of self-neglect, that there's some gold nugget, even if it's one thing you take away that is a gold nugget for you from today. Because you'll find on your tables that there are some evaluation sheets, and before you're all groan, it's not the kind where, you know, you sit here until you've filled it in at the end of the conference. It's an evaluation sheet to fill in over time to see whether today has actually helped to inform your practice in any way, because you'll be going through toolkits that have been developed recently in this afternoon's exercise session, and we'd really like feedback of, do they work for you? Are they helping you in your day-to-day practice? So on that basis, I'd like to hand over to Robert, who's our first speaker. Thank you.
want me to move it on? It's still on there.
This also works. There we are. Oh, just put that one.
Right.
And
And then
just, where is it? There we are. If you click on it, there you are.
hold on.
This will work if you want a hand.
Good morning. I'm Robert Lake, as you've heard. It's very pleasant to be here in Aylesbury, although I wish I wasn't, because it's only because a young woman died that I'm standing here. Okay, I was asked to do the review, which I did, and which was, I hope, well done and certainly well supported, but it's a tragedy here that I'm here in a sense, so. But nonetheless, it's delightful to be with you. This was case T, Ms. T. I must admit, one of my slight bugbears is that whenever I'm authoring SARs, and I've done about 20 now, I try and give the person an actual name, because to me it's important that the person still lives through the paperwork. But whatever, here we called her Miss T. She was actually found dead. She was only 34 in February of 2016. But prior to that, the last time she had been seen was the previous November. Because of the state of decomposition, and I must admit, how our colleagues in the ambulance service and the police service deal with issues like this, and indeed coroners and others, I just do not know. But nonetheless, an advanced state of decomposition, so we couldn't find out what she'd actually died from. She was born here in Buckinghamshire and was of Asian background. She studied accountancy at university, but as far as we could ascertain, apart from the odd part-time job here and there doing an odd bit of accounts work, she didn't really have any regular employment. In terms of her physical health, she had asthma. She had type 2 diabetes, which was quite poorly controlled. I don't think she was particularly good at taking the medication. She also had a history of mental ill health. Back in 2011, she'd been made subject to a section for paranoid schizophrenia. It followed an attack on her mum. And from that date through to 2015, she was subject to the care programme approach, which I assume most of you know what it is, but effectively it's a way in which the mental health services continue to support somebody through care, through a programme of care. In November 2013, or by November 2013, she had met up with a guy, but her family were not best pleased at her making this relationship, and in fact they disowned her effectively. Nobody wanted anything to do with her from her family, and I'll come back to that in a moment or two. She did become pregnant, but in November of 2013 she had a miscarriage. Some little while after that, her partner returned back to India. We're not sure whether it was just because his visa ran out or because he was actually deported, we don't know, but he was no longer there, and she had been supported not just by him but by his family as well. She became homeless, but thankfully one of your local housing associations rallied round and found her a tenancy in August 2014. In July 2015, so a year on, Housing Association reported that she was managing extremely well. The house was immaculate. She seemed to be thriving. She was doing quite well. And because of that, perhaps, the care programme approach, the mental health support, it was felt that it could be safely withdrawn. Because she was doing well, we're all under this pressure all the time. We've got people that we're trying to help, and if they reach a point where we think they're doing well, then we close the case. And I'll come back to that as well. Now, critical period now, from September 2015 really through to November. Her GP, who, if you'll excuse the phrase in this context, who was one of the stars of this case, So the GP was incredibly tenacious, tried so hard to do all that she could to help Miss T. And on 2 occasions in September, she phoned her, didn't get any reply. And then on the 8th of October, a friend of Miss T, we don't know who she was, but a friend contacted Adult Social Care. She said, well, I've not seen Miss T for a long time, and we're normally in touch, and I'm a bit worried. The police, and they are another star of this particular case, the police visited, were able to see Miss T. They were a little concerned because there was no food in the house, no food in the cupboards at all, and the house was not very clean. Now compare that with just over a year earlier, where the house was immaculate and she was coping well. The police quite rightly made a referral through to Adult Social Care and to the Housing Association. And then in a 10-day period, in that 19th to the 29th of October, Adult Social Care, a mental health triage service, which the GP had triggered, and the GP and the police, they all attempted again to contact Miss T over that 10-day period, but without success. By the 31st of October, the police decided that the situation was such that it warranted a forced entry. And they did so. Miss T was found there. She was relatively okay. Paramedics were, I think, in attendance from the word go. They checked her over. No further action was required. She seemed to be okay. On the 9th of November, the Housing Association officer visited, no reply. But then on the 12th of November, Miss T phoned Adult Social Care. That's because when Adult Social Care, remember the case had been referred to them by the police, when they'd not been able to contact Miss T, they'd written to her and said, look, we're just a little concerned about you, can you please let us know if you're okay or whatever. And indeed she did. She rang them and said, I'm fine, thanks. I'm fine. No worries. 5 days later, remember the police made a forced entry on the 31st of October, and bless them, in the way that they do, they'd smash part of the door frame. Inevitable, really. So Miss T contacted the police because she wanted an incident number, because she wanted to be able to tell the Housing Association and get the door repaired. Clearly, if she'd damaged it herself, the Housing Association might have taken a different view, but as the police had done it, backed up by an incident number, then the door would be repaired by the Housing Association. Now, on the 23rd of November, the GP refers Miss T back to a mental health team. I say back because back in August, said the mental health services have felt, well, she's doing very well. We don't need to keep her on a case, or we're going to close the care programme approach. The GP, incidentally, at that time, in August, objected to that. Said she didn't think it was a good idea. But the mental health services, for whatever reason, and maybe for good reason, decided, no, we're still going to close the case. But on the 23rd of November, the mental health team again referred the case through. The GP again refers the case through to the mental health team. And indeed, the team made a number of abortive phone calls. They just couldn't get hold of her. Now, there's a bit of, it's not in here, but there's a bit of concern around this period because having made some sort of contact, or tried to make contact, the mental health team then went back to the GP and said, actually, I think we need a physical health assessment first. I think you need to go out and just check if she's all right before we get involved. Now, that doesn't make sense to me. The GP had referred for a mental health assessment. That should have happened. And it didn't. It was referred back. And somehow that all fell into a void. I think it's because the GP was actually on leave and it was a colleague who took the call and the messages may not have got transferred through properly. Whatever. There's a sort of period of a void where nothing is happening. And indeed, on the 23rd of November, a Housing Association member of staff visited, saw Miss T. Everything seemed reasonably okay. I think it was largely about repairing the door. but that was the last time she was seen, at least by any professional in any of the partner agencies. Whenever there are SARs, there are usually, sadly not always, but usually there's some good practice which we ought to celebrate. Now, I've mentioned a couple of these in passing already. The GP was incredibly tenacious. She knew that in Miss T she'd got a patient who didn't look after her medication for her diabetes properly, in general was struggling, had a history of mental ill health. She stuck with her and tried her very best throughout all this period to keep in touch and to keep Miss T healthy. The police, as I say, they went over and above their duties, really. The police, as I understand it, and I'm sure there's police officers here and they'll correct me if I'm wrong, but as I understand it, the kind of welfare visit thing isn't necessarily something the police regularly do. But in Miss T's case, they did. 3, 4, 5 times. And in fact, there was one particular day when Miss T had been reported missing, when the police kept a check on it almost hourly, trying to see was there any progress, was there not. And that's what led eventually to the forced entry. But the police really stuck with it. When you think of all the pressures the police are under, you know, the odd person who may or may not be at home and we're not quite sure whatever, you could see why it would be given a low priority. But not in this case, they stuck with it. The Housing Association had given Miss T her tenancy, they supported her throughout it, they kept regular contact, insofar as the Housing Association does. Let's remember, when you're a tenant, lots of tenants don't want to know, they just want their tenancy, and as long as they pay their rent, fine. But they did keep in touch with her from time to time, and indeed, as I said, it was a Housing Association member of staff who was the last to see her. And adult social care, they only had a marginal role in this. But at the point where it was referred to them by the police, they did try and contact Miss T, and when they failed, they wrote to her, and indeed that led to the phone call that she made to them saying, "I'm fine, thanks." So adult social care had done what we would expect of them. Whenever we do a review like this, I don't know how many of you know what the mechanics of them are, but often what we do is we call for individual management reviews to come in from all the partner agencies. And as part of that, we ask them, having considered the case from their perspective, what are the things they identify that they need to do to put right? And indeed, in Miss T's case, there were a number of single agency action plans where the individual agency has said, this is what we need to do, this is the learning from this for us, this is what we're going to do to improve. Thankfully, in many cases, because of the passage of time, remember we were doing this review this time last year, and she'd actually died in 2015. I mean, things have been done. A lot of the action has already been taken, thankfully. Please, if you're ever involved in a case like this, don't wait for the case to be finalised by somebody like me. Get on and put right what you know is already wrong. And those action plans were done. They were received by the Safeguarding Board and have been reviewed regularly since until they could be signed off as completed. I made a number of recommendations to the Safeguarding Board, and when I say I, what I ought to do is acknowledge the fact that I didn't do all this work on my own. I was assisted by a panel drawn from your colleagues from various agencies who supported me in going through all the background information, all the detailed information, and helping me to write the report. So thank you to them for that. But we made a number of recommendations. One was to revise your self-neglect toolkit, and I see we've got it on the agenda later on, which I'm very pleased about, so that's certainly gone on. At the time of all this going on, your MASH, your multi-agency safeguarding hub, was very much in its infancy. It wasn't really functioning. So I was saying, please review the operation of the MASH, which I assume has been done, I hope it's now functioning well. There seemed to be a lack of understanding of when do you go for what's called a Section 42 inquiry? That's where there are safeguarding needs over and above any care and support needs that a person might have. The care and support needs assessment, if you want to know, for the techies, is Section 9 of the Care Act. But Section 42 is those where there are safeguarding concerns. And at the time of Ms T's death, we identified that there was a lack of understanding of when do you do a Section 42 and when do you not, and what are the thresholds? At what point is somebody's safeguard or need for safeguarding comes to the point where it needs a formal assessment? And that wasn't clear at the time. And I've just been seeing on the table, I don't know if, yes, there seem to be on all the tables, there's this laminated card showing you a lot of stuff about thresholds there, which I've had a quick glance at and looks first rate to me, if I dare say so. There wasn't actually any policy in force in this part of the world in Aylesbury around missing persons. Interestingly, the police, your local police, were trialling it elsewhere in the county, in their wider area, because clearly it's Thames Valley. But it hadn't reached Buckinghamshire and Aylesbury. So what we were saying was, there's already a missing persons policy effectively on the table. Will you please have a look at it? See if it works for you, and if so, adopt it. I mentioned the police welfare visits, and I think part of, we needed, what this case, one of the things it said to us was, you need to review how you actually, when are you doing a welfare visit, when are you not? And I say, I think the police acted absolutely as they should have done throughout all this, so there's no criticism. But again, I think there was a lack of understanding by other agencies as to what constituted the grounds for a police welfare visit. You know, getting the boys and girls in blue to go and knock on somebody's door and, if necessary, break it down is a pretty, it's a big step. We all ought to understand when, where, how do those things happen. One of the issues that came out of around Miss T was at the time that she was experiencing her difficulties, your local mental health services were undergoing a review and a reorganisation. I suspect just about every agency represented here today has been going through or is going through some sort of reorganisation, not least in response to the constant need to save money, so we've got to try and find another way to do things, so we do. The problem is, when those things are happening, the eye goes off the ball. We sometimes get ourselves so embroiled, understandably, in what's going on around us in terms of reorganisation. Am I going to have a job next week, and if I am, what is it I'm going to be doing? Very understandable. To the point where sometimes the people who are trying to serve get put sort of in second place. It also means that for some of the other agencies, they don't know what the referral routes are now. And when I was doing this review, I got very confused, and I still am really, about the various bits of the mental health service at the time. Who would do what, who you should refer into for what. And there's something there, and I'll come back to it in a minute too, there's something there about making sure we each know what other agencies are doing whilst they're reorganising. Not least because there's some things which agencies do with the best of intent, but in doing so, they make problems for one of the other partner agencies. Not intentionally. It's a classic unintended consequence. But we need to keep all those kind of things under review. I mentioned the fact that Miss T, a friend of hers came forward and had said, I'm worried about Miss T. Now, as it turned out, on that occasion, Miss T was still relatively okay. No feedback went back to that individual, just a member of the public. And it's a really tricky one, this, about can we share what is very personal information, even more so now I'm sure you've all been having emails dropping into your inbox about the new rules on information sharing. Well, it's even tighter now, but could we not at least have gone back to that person and said, look, we found she's okay, but can you please keep in touch with her and let us know if you have any further worries? That didn't happen. Now, who knows? It may not have made the slightest bit of difference at the end, but on the other hand, it could have done. So there's something about exploring what information we can give to third parties and how. Remember, increasingly, the community are our eyes and ears. They always have been. But with the constant reduction in the professional workforce, we need to work much more closely with those partner agencies or individuals who are out there as members of the public. Marie mentioned a bit of the work that's been going on around SARs nationally, and I thought I'd just share with you some of the work that's been done by three academics, Mike Preston-Shute, Susie Bray and David Orr. If you Google them, you will come up with what I'm talking about. So if you feel encouraged to go away and read in more detail, please do, because all I'm going to give you is the headlines. But these three have looked at all the SARs on self-neglect that have been published up to about, I think it was the middle of last year. And they found some common themes. And I thought I'd share these with you as part of your day-to-day looking at self-neglect. They don't all apply to Miss T. Some do, some don't. The first one of these is that there's a failure often to really follow the principles of making safeguarding personal. Now, I'm assuming in this room I don't need to explain what making safeguarding personal is, but I will anyway, just in case anybody's not sure. It's actually something that's been published by the Local Government Association, although it originally started its life, I think, by the Association of Directors of Adult Social Services. And what they're saying is there's a number of key principles, I think there's 7 or 8 principles, that we should follow when we're working with people in order to make safeguarding personal to them. A lot of our safeguarding experience is actually in safeguarding children. When you're safeguarding adults, statement of the obvious perhaps, but it's a very different world. We can't act in the same way. For children, we would act much more on their behalf. With an adult, you can't. We need to work with them. I mean, take neglect. If a child is being neglected, and incidentally, as far as I understand it, and I chair a Safeguarding Children's Board down in the southwest, neglect is still the single biggest worry in the context of child protection. It's not the one that gets all the headlines. That's things like child sexual exploitation, which is very real and needs a lot of attention. But in pure number terms, there are far more children being neglected than any other form of abuse. Now, if you come across a child who's been neglected, it's relatively straightforward, hopefully. The agencies come together and protect that child. If somebody's self-neglecting, it's a very, very different issue. Because is it their choice? What is it? I mean, we're going to be hearing shortly from our colleagues in the fire service talking about hoarding. I mean, a real fire hazard. It's their choice to hoard, but they could leave themselves in a very dangerous situation. Now, making safeguarding personal starts from the assumption that the individual determines what is the outcome that they want from the professionals' intervention. Now, Mike Preston-Shute and Susie and David found that making safeguarding personal wasn't always being applied properly, not least in the context of consulting with significant others. By that I mean other members of the family, or a neighbour who is significant in that person's life, or whatever. Again, it's got to be carefully done because of confidentiality. But we fail often. We talk to the individual, but not to those around them. Sadly, in Miss T's case, there was nobody around her. There was the friend I've mentioned, and maybe we missed the opportunity to for that person to become a significant other in Miss T's life. Another finding from Mike, Susie and David was that we often fail to recognise the real impact of bereavement and loss. In Miss T's case, she'd lost her family. She'd been ostracised by them, fairly or unfairly, rightly or wrongly. Was it purely a cultural issue within that particular group? Who knows? But the fact is, she lost her family. She then gained another family of sorts through her partner, but then he left. Again, she lost him, she lost his family, and perhaps most significantly of all, she lost a baby. What was the impact on Miss T of those experiences, those losses, those bereavements? We don't know. And often when we're dealing with somebody who, to all intents and purposes, just self-neglecting, maybe it's because they are really, really, really in a terrible place because of the bereavement and loss that they've suffered. We need to think about that. We professionals, fail to worry. The GP did, bless her. She worried. But in many cases we don't. The kind of pressure that we're all under day by day, we deal with what's presented to us with a particular person we're dealing with, and then we move on to something else. We don't sit and worry about it and think about it. It's pressure of work, we all understand that, but somehow we need to try and find the space to worry a little about what's going on for some of the people we're trying to help. We need to be curious, professionally curious. I don't mean being nosy. I trained as a social worker, and I suppose I'm a professional nosy person. I hope I'm not, but I hope I did have professional curiosity. Just to ask a little bit more, find out a little bit more. I know it all takes time, and time is of the essence, but just be a bit more curious. Just think, talk it round. Again, Marie sort of mentioned this. I know we're going to have a session on mental health, but we often get muddled up between Mental Health Act assessments and Mental Capacity Act assessment. A couple of us were talking before we started. Mental capacity isn't that difficult to do. So I think maybe what it is because it doesn't give us the answer we want, we don't use it. If we're dealing with a person who's clearly self-neglecting, and we think, all right, I'll check their mental capacity, and we do, and it comes out as they have capacity, well, no, that can't be right. They can't have capacity. If they have, why are they continuing to do what they do? Well, they do have mental capacity, but one of the big tricks is, have they got the power to do what they say they can do? The executive capacity. Mike Preston-Shute will tell you of a particular case that he was involved in where a lady was severely disabled, couldn't move, but she liked to fag. She liked lots of fags. And she was advised, look, for goodness sake, if you're going to smoke, at least use a cigarette lighter. Because if you drop a cigarette lighter, it will go out. And she said, fine, yes, of course I will, of course I will. Some little while later, she died in a fire, sitting in her armchair, because a cigarette she'd lit, the match that she'd used to light the cigarette had dropped her into her lap. She'd got flammable clothing on, and she died what must be one of the most horrific deaths possible. She could talk the talk, but she couldn't actually walk the walk. Now, how often do we not take into account whether somebody's got the executive capacity, not just to say, yes, I can do it, but can they really do it? And there is a tendency, I said, for us often to use the Mental Health Act instead of the Mental Capacity Act because there's more of a certainty of it to it in a sense. We're all much more used to it. Some of us have been around almost as long as the Mental Health Act. In 1950s, not quite, but whatever. It's there, it's long established, we all know how it works, we know what the rules are. We feel more comfortable with the Mental Health Act than the Mental Capacity Act, but in fact, so often it's totally erroneous. And it takes us down the wrong road. Instead of concentrating on somebody's capacity to be able to do what they say they can do. I've said one of the themes that's emerged during this talk has been time. And we are all under immense pressure all the time. And because of that, we tend to, I'm not saying this was true in Ms T's case, although arguably it was at the point where the mental health care programme coach ended. Because somebody seems to be okay and because we've got a lot of pressure, we close the case. Or we maybe transfer it to somebody or refer it to another agency and think, fine, they'll get on with it, we don't need to worry about it anymore. Before you close, there are cases clearly that need to be closed or transferred or referred on. I'm not saying that isn't true. But before you do it with one of the cases you're involved in, will you just step back and think it through again? Again, I'm not saying that in Ms T's case, had the mental health team stayed in contact with her, that things would have been different. We don't know. I mean, one of the things that every SAR tries to answer is, was the death avoidable? To be quite honest with Miss T, I haven't got a clue. I still don't know. There are opportunities that were missed maybe to intervene or whatever, but she was a very private person. And say, because we don't know how she died, what she died from, how can we tell? But just maybe, if people had kept engaged when they pulled out, maybe she might still be alive. One of the other things we often fail to do is to do a proper risk assessment. I mean, you probably think to yourself, no, don't be stupid. But the research, and these three people are very eminent researchers, and I've come across it too, where people just fail to make an assessment of risk. What are the chances that, in this case, Miss T is going to die? I mean, that is particularly dramatic, but on a much lower level, what are the chances? I mean, the case I mentioned about the lady in the fire and the cigarettes and the matches, there was a risk assessment, and the risk was found to be real, and the advice was given quite properly. So that one, fine, there was a risk assessment. But without going into any more detail, I can think of cases I've been involved in where risk assessments have not happened. Can you please make sure you do one? It doesn't need to be a massive exercise. Just sit back for 5 minutes and think, what are the risks here? What are the things that could lead to something happening that we wouldn't want to happen, and how can we prevent it? So that kind, just a simple kind of thing. A bit of one for the non-techies. Standalone IT systems. So often, IT systems don't talk to each other. I've come across in one or two parts of the country where actually the reverse is the truth, where adult social care has access to health records, health has access to adult social care records, and the health records include the primary sector, the secondary centre, the mental health. That's the way it should be. I know we've all got to be careful about how our information is shared one with another, but we're talking about people who are seriously at risk. It's perfectly proper and legitimate. In fact, if you go, there is nothing anywhere in the legislation that says anything other than if you have concerns, you should share them. And I know that there's particular professions, GPs are often cited, and I'm not sure they're alone, and I'm not sure they all do it, who say, no, I can't tell you, it's client patient confidentiality. There's one word for that, and it begins with a B and ends CK at the S. It is not true. If someone is seriously at risk, we have a duty to inform each other. It's actually a duty on all of us. So, it'd be lovely to get to a position where IT systems can talk to each other. At one point in my career, I spent 4 happy years at what was called the NHS Information Centre for Health and Social Care. It's now called NHS Digital, whatever that's supposed to be. But as part of that, one thing I did was I sat on what was called the NHS Number Board nationally. I'm sure you all know, and you will know them off by heart if I ask you to recite, I think not, but never mind, what your NHS number is. 12 digits. What was trying to be attempted was that by using the NHS number, that health could actually share information, and indeed adult social care could equally do the same. Never happened. Still not happened. But wouldn't it be fantastic if, what would have happened if last night when I arrived in Aylesbury late at night, what if I got knocked down by a car? Rushed into your local hospital, A&E. They wouldn't have a clue who I was. If I was unconscious at the time, I couldn't tell them. Now, they'd be able to tell from my driving licence or whatever that I got with me who I was. They should, through that, be able to trace back some health records and maybe find out there's something on my health records somewhere in the country that tells them they mustn't do something or other, like give me a particular anaesthetic. We haven't got any of that. When are we going to get to the point where in this information-rich service, where we each in our pocket have a computer more powerful than a room full of computers when I was a kid? When are we going to learn that we can actually talk to each other and should talk to each other? There's often a lack of feedback to others on safeguarding referrals. I mentioned the idea of can we give some feedback to third parties, but we often don't even share it with each other. You know, maybe a district nurse refers into adult social care, a safeguarding referral. Does that district nurse always get some feedback? Maybe they do here. I'm just asking the question because it doesn't happen everywhere. And that's not just the only partnership. Obviously, there's others. We need to refer back. When somebody's referred in, let them know what's happening. Marie mentioned, I think, in her presentation about the feedback forms and getting some idea of if you find not just this useful, but lots of the other things that the Safeguarding Board does useful. Mike, Susie and David found that often the policies and procedures created by a subcommittee of the Safeguarding Board, Policy and Procedures Subcommittee, an obvious name, but they don't make sense at the front line. They might make wonderful sense at that middle and senior management level, but they actually have no sense whatsoever to those of you who are out there trying to do the business face to face. So, all we say is, if you're doing policy and procedure development, road test it. Get some of the practitioners to help produce it, and then get it road tested. Nobody in industry would dream of launching something onto the market that hasn't actually been consumer tested. We do it all the time with policies and procedures. I've mentioned the impact of organisational change. I've talked about that and where it did happen in Miss T's case, where things were happening locally, people didn't know what the referral pathways were, and other people's eyes were off the ball. Make sure it doesn't happen, because organisational change is endemic. I mean, particularly in the NHS, they seem to have one every week. Not trying to be too unkind, but it does feel like that. So remember, there can be unintended consequences from something that you're having to do, but just make sure that it's tested out. And I've said, in passing here, that I've said earlier on, we don't always use Section 9 and Section 42 properly. Section 9 is where an individual has care and support needs. And Section 42 is where there's a safeguarding need. Now, not everybody who's got a safeguarding need has necessarily got a care and support need, and clearly somebody who's got a care and support need doesn't necessarily have a safeguarding need. And there are some who don't meet any thresholds whatsoever. So again, the document you've got, your laminated thing there, as long as it makes sense at the front line, should be very helpful. But, and I'll finish on this, the last major learning point from these three academics, and indeed perhaps from every safeguarding review, both adults and children, for the last 40 years has been poor communication. When will we ever learn? You can go back to what we now call a serious case review for children, but go back to the old serious, whatever they were called then, I can't even remember. Names like Stephen Menheniot, many, many years ago. And every review since has found poor communications. Even in Miss T's case, although there was some very excellent work going on in silos, people weren't talking to each other properly. If only we could learn to share the information we have, then maybe, just maybe, we might save somebody's life. Thank you.
Can you use a clicker or just do it? Do it. Which one? You just put there, and it'll click forward. And so you just press on here and it'll run to the next page,
Okay.
or you can use that.
Thank you, Robert. So as you've heard, there were 2 safeguarding adult reviews completed last year, and the second of them was one that we entitled Adult Q. Now, we anonymise these cases for, I hope, fairly obvious reasons, but one of the risks is when you hear the term adult Q, actually you don't think of a person. So what I'm going to do to start with is to talk a little bit about who adult Q was. So he was a 74-year-old man who lived alone. People who knew him painted a picture of a man who'd lived a very varied and exciting life. He'd travelled the country, on the road, driving a lorry or riding a traditional horse-drawn caravan, or on the canal network, travelling and living on a barge. During his life, he had been married and he'd had a son, but he'd lost contact with the wife and the son after they moved away. He settled in Buckinghamshire and became a part of the local village community with one particularly close friend, who again we've anonymised as Ms Y, who he used to see regularly. They went on trips and he became part of her family. She described him as like a second father to her. Over time, Ms Y began to provide adult Q with a significant level of support, helping him to look after himself and his home. He was a well-known character in the village and a member of a local church, attending social groups during the week, services on a Sunday, especially liking the music, and he'd always joined in. Give you a sense of perhaps what he was like as a person. But he also had some complicated needs. He had a diagnosis of bipolar affective disorder. Some of you may know that better as manic depression. So someone who has periods of depression, of low mood, but also periods of mania, periods of elation. And those times can be characterised, as in adult Q's case, by spending money inappropriately. He had ankylosing spondylitis, I think that's how you pronounce it, a long-term inflammatory condition affecting the joints of the spine. And he later also had a diagnosis of Parkinson's disease. Now, adult Q died on the 6th of April 2016, and the cause of death being noted by the coroner to be bronchopneumonia. At the time of his death, a number of agencies were involved with adult Q in the context of his health and needs for care and support. Agencies also became involved in a crisis period, responding to an allegation of financial abuse and concerns raised through his care provider and informal support networks. Adult Q, as a result of his physical health needs, did have
what we call a domiciliary care package. So he had a care agency involved, he had carers calling in to see him at home to meet his identified care and support needs. But he didn't always let them in. And when he did let them in, he didn't always let them do the task that they were supposed to be doing for him. So they were raising concerns. And the informal support network, so if you've heard, he had a very close friend, he was well known in the local village, he was well known in the local church. They were raising concerns about his mental state. Had his bipolar affective disorder deteriorated? There were concerns about his home environment and behaviours of self-neglect. So after his death, a referral was made for a safeguarding adult review because of initially concerns about how the various agencies involved with Adult Q, and there were many people involved with Adult Q, how well were they communicating with each other? So we considered whether the referral in these circumstances met the criteria for a SAR, and we agreed that they did. So the review methodology draws on systems learning theory. So what the report author did was look at how information and relevant evidence gathered through the case were evaluated and analysed. So incorporating learning from research and from other reviews locally and nationally. So agencies involved in the care of Adult Q were asked to provide chronologies. So when did they see him? What dates did they see him? How long were they seeing him for? What were some of the issues? And each agency then carries out what's called an internal management review, really looking at what their agency did, some kind of analysis about did they do everything that was needed to be done. And those IMRs had agreed terms of reference. And the practitioners who knew and worked with Adult Q were also invited to contribute to this through a multi-agency practitioners event. We couldn't involve Adult Q's family in this, as he had lost contact, as we've heard, with his wife and his son. However, his close friend and a representative from the local church were asked to contribute. So the terms of reference that were agreed here, so what was it that the report author was being asked to look at? These were set out in terms of reference. So the first one is quite clear. What were the circumstances of his death? What were the events surrounding his death? And were there ways that agencies could have worked more effectively to safeguard him and others? So it's all very well to say there were lots of agencies involved with him, but he died in circumstances that were raising concerns. So one of the obvious questions that come with that is, was there something that went wrong? Were all those people and agencies involved with Adult Q doing everything they should have been doing and doing it effectively? We needed to look at legislation and policy. We've heard a lot from Robert about the Care Act, particularly duties under the Section 9 and Section 42, and also the Mental Capacity Act and Mental Health Act. We're going to be hearing a lot about Capacity Act and Mental Health Act today, and Tasha and Sarah, who you're going to be hearing from later, will be explaining that very succinctly in a very short period of time. We also need to think about the learning from previous case reviews. So safeguarding adult reviews, that's been the terminology we've used since the Care Act was implemented, but we've been doing serious case reviews for adults for a number of years. So there are various reviews that have taken place in Buckinghamshire, action plans from each of those, but one of the things we've highlighted are common themes coming through. So when you get those common themes, what's happening? If we're doing reviews that are coming up with the same thing each time, then what went wrong with our action plans? We have to ask ourselves that. I wanted particularly to look at information sharing, communication and coordination of multi-agency care. One of the challenges when you have different agencies and different professionals involved with one case is that there's a real risk of either duplication or omission, assumptions made about who's doing what. If we're not communicating effectively, there are real risks there. How are Adult Q's complex physical and mental health needs met? And are there lessons to be learned from the circumstances of the case in how the local professionals and agency work together So when we do a safeguarding adult review, we're committing a lot of resource to this. So we need to know, what is it we're going to do with that? Are there lessons to be learned? What are we going to change in the future? So, the findings. Adult Q died in his own home in 2016. He had, however, been discharged from an inpatient stay in an acute hospital 9 days before, certainly less than 2 weeks before. The cause of his death was bronchopneumonia, with associated conditions of the severe kyphosis secondary to ankylosing spondylitis, so that the physical conditions he's always had. So his death was secondary to that. And again, you've heard from Robert about, was the death predictable or preventable? It's difficult to say, as it often is, but the circumstances of adult Q's death did highlight a number of concerns about the ways agencies work together to safeguard him, including responses specifically to self-neglect and a possible deterioration in his mental health. So these were, in terms of the terms of reference we've just gone through, the second one around multi-agency working. So the author here thought that individuals who self-neglect would benefit from an allocation of a named worker or lead professional to oversee and coordinate the various different interventions attempted to provide them with support. So where you've got lots of different things going on and a real risk of duplication and omission, having one key person identified would be useful. And where individuals are at high risk of self-neglect, the Risk Assessment and Management Panel, or RAMP process as we call it, is available to offer professionals multi-agency support, advice and consultation. And you're hearing about the RAMP panel later this afternoon. Legislation, the Care Act. Had the Care Act a few years now, but there are still some issues with understanding, as again Robert's already highlighted. And as the author here has identified, an individual's risk of self-neglect can often be masked by the efforts and interventions of informal carer support. And professionals must seek to assess a person's risk with this in mind, considering ways to prevent risk and increases in care and support needs through supporting the informal network, whilst considering how to protect individuals from increased risks should informal carers be unable to continue to support the individual. Now, just to give you a little bit of context here, I mentioned earlier about Ms. Y, who was this really key person in adult Q's life. He was referred to as almost like a father figure for her. But an allegation had been made about her. Now, adult Q had for many years an arrangement with her. She managed his money on his behalf. When he was mentally unwell, one of his what we call relapse indicators, an indicator that he was mentally unwell, was that he would spend his money inappropriately. So she managed his money on his behalf to make sure that that didn't happen and he had enough money for the essentials. Now, at one point, adult Q decided he wanted to spend some money on something. Ms. Y thought that actually was an indicator that he was unwell and she didn't want him to spend that money. So a safeguarding adult referral was made, a concern was highlighted to say, was she managing his money inappropriately? Was there something going on that shouldn't have been? So Ms. Y was made aware of that and withdrew then. She wasn't quite clear what to do. This allegation had been made. She was very concerned about it. It needed to be investigated. During that period of time, it wasn't clear to her how involved she was still able to be. So, to err on the side of caution, she withdrew. He then was left without this really key person supporting him. And the point made here is that that hadn't really been considered. The impact of her stepping out of his life hadn't been considered. Equally, should she have been given more guidance about what she could still be involved with, this really key person in his life? Then looking at self-neglect pathways. One of the key changes with regard to safeguarding adults in the Care Act was that self-neglect became a safeguarding issue. And I think professionals still struggle with this. I think we all do. Robert has already raised the question of choice. And do we think that people are making the choices to live in certain conditions? As social workers, we are really trained to not impose our own standards of living, our own values on other people. We should be respecting their choices. So it can be really tricky then if you're intervening with someone who is not living their life in a way that appears safe, whether they aren't undertaking their personal care, whether the house isn't in a good standard of cleanliness. All these things could indicate self-neglect. And one of the key learning issues here is that how do we make sure that that self-neglect is identified and considered through a safeguarding lens? When we look at it, are we looking at it as a safeguarding issue? Rather than just someone is choosing to live that way and we wouldn't want to impact on their choice or take that choice away from them. So there's a recommendation for the Safeguarding Board to obtain quantitative and qualitative data on needs assessment and carers assessments to ensure that professionals do understand the duties placed on them under the Care Act. The Mental Health Act, 1983. It's been around a long time. We should all be familiar with it by now. Now, referral pathways should be clear, consistent, easy to understand and navigate. I work in mental health services and I'm also an approved mental health professional, so I'm pretty familiar with the Mental Health Act, and many of us working with mental health services are. But we do assume that everyone else is too. So when a referral is received for urgent or crisis mental health assessment, the referrer should be informed of the outcome, including whether a Mental Health Act assessment will take place or alternative interventions are to be offered. Now, Tasha will be going through this in some detail a little bit later, but just to give you the context in this case, so there had been 2 referrals for Mental Health Act assessments for adult Q, one of which had happened fairly early on when there were concerns, and the referral went through the community mental health team for older people. Now, they picked up the referral and went out to see adult Q to see what was going on for him. They did, in many ways, what is the right thing to do. A Mental Health Act assessment is a really complex, very formal, somewhat oppressive, inherently oppressive piece of work to do. So we would always expect that a mental health team went out to see, actually, is this what's really needed? And in this case, the older adult mental health team did just that. They went out to see adult Q, they worked with adult social care, and they were seeing him every day. The older adult community mental health team were having a lot of regular contact with adult Q to assess and manage his mental health needs in the community. Their view very clearly was a Mental Health Act assessment at this time wasn't needed. We only really look at a Mental Health Act assessment if someone needs to be admitted to hospital and likely to need detention under the Mental Health Act, or sectioned is the term that's used. If that's not the case, then we really need to explore every other option to meet and manage mental health needs in the community first. And that's what took place here. But that feedback wasn't given to the GP who'd made the referral. The second Mental Health Act assessment referral was made a little bit later on, and this one did go to the approved mental health professional service. They picked up the referral, attempted to make contact and find out what was going on. But in the meantime, there'd been a concern for welfare for adult Q, and he had been found collapsed in his own home and taken to hospital. Now, adult Q lived in the south of Buckinghamshire, so his local hospital was over the border in Slough, and he had been taken there. And what the approved mental health professionals did was they contacted that hospital and said, we've had a referral for a Mental Health Act assessment, he's now with you, we need to know how to proceed. And what happened was he was seen by what's called liaison psychiatry. So when you have mental health services sitting with an acute general hospital, they're often called liaison psychiatry. They assessed adult Q's mental state and said, We don't think there are any issues with his mental health at the moment. We don't think a Mental Health Act assessment is needed. If it had been, then the approved mental health professionals from Buckinghamshire would have gone over to that hospital to undertake it. But the clear message they were given was, his mental state seems fine to us, we don't think that option's needed. But again, the feedback from that, the outcome of considering that referral wasn't given to the GP. So in this case, Adult Q had arranged for a friend to manage his money, as we've heard. Already heard the issues of that with regard to safeguarding, but also what wasn't considered at that time, arguably as much as it should have been, were that the circumstances of the allegation, and Adult Q wanting to spend money that his friend thought was inappropriate and prevented him from doing so, that in itself was an early warning sign that his mental state was deteriorating. Was his mental health really considered at the point that the safeguarding practice was happening? That didn't happen till later, so arguably it could have happened sooner. The links weren't put together. Learning from previous case reviews. So, self-neglect has come up before, and there was work done around self-neglect. We've heard about the Risk Assessment and Management Panel. That had come out of previous cases. In terms of knowledge and skills, we'd heard before about Mental Capacity Act awareness. Skilled interventions, in terms of having nominated trained practitioners, time and resource to enable holistic work. There's a reference here to performance-driven areas of practice. Now, different agencies have different priorities for their practitioners to be focusing on. We've heard from Robert about what impact that had for someone under the care of mental health services. You no longer meet our criteria, we're discharging you. Do people fall through the gaps in the meantime? Do we forget about professional curiosity, perhaps, because we get focused on what my role is with my agency in this circumstance? Heard about operational guidance and toolkits. But again, Robert has covered this, we need to know that where we've launched something, where we've completed work, we've undertaken a review, panels or groups of people have thought this is a good idea, we need to implement that. Have they been implemented properly? Have they really made a difference? Do practitioners locally know of them? Is it helpful? And in terms of shared decision making, working in a multi-agency approach, do we do this well? Or do we tend to just focus on what my organisation is doing? Communication between agencies. Now, we've heard here lots of different agencies involved with Adult Q. One of the main differences between Adult Q and the case you heard earlier, Adult T, is that Adult T had pretty much fallen through the gaps. She wasn't being seen, lots of concern about her. This wasn't the case with Adult Q. He had lots of people involved with him, right until he was discharged from the acute hospital. But were they communicating properly? The real issue here I want to highlight is that, as I've mentioned, that Adult Q was discharged from an inpatient state. Being an inpatient, was actually admitted into Wexham Park Hospital, was discharged from there, and the communication went wrong. People didn't know he was now home. His GP didn't know he was home. The discharge letter that the hospital sent his GP arrived after he died. It's not rocket science. Physical and mental health conditions. Now, we've heard Adult Q, really complex needs. And one of the things the author of this report thought that we really need to focus in a recovery way, Now, recovery within mental health, terminology that's used, some people use the term recovery model. I don't particularly like that because recovery is a very personal experience for an individual experiencing mental health issues. But the recovery approach, very basically, is about identifying with someone where they want to get back to. What is it they want to be doing? What is it they want to be achieving? And how do we support you to get there? It's very much moving away from you have a mental illness, therefore the rest of your life will be about your mental illness and you'll be under the care of mental health services forever. It's very different these days. So that is already in place. But the challenge with that, when you do work in a recovery-focused way, it's very much about providing episodes of care, providing specialist mental health services to people for relatively time-limited periods until their mental health issues have lessened, until they're functioning better. Downside of that, we've heard with adult T, you get to a point where your mental health needs suggest you no longer need to be under the care of secondary mental health services and you're discharged. So what happens in the meantime? Heard about individual management reviews. Now, these are often part of a process with completing a safeguarding adult review. The various agencies involved with someone are asked to complete an individual management review. But different models, different authors undertake different models of review. So it's really important that IMR authors are aware of the methodology being proposed so that when authors get the reports from the different agencies, they're in a state that he can pull them together. The author, in this case, could pull them together. Cross-border hospital admissions. Now, I've already mentioned about this, that adult Hugh lived in the south of the county. For many people who live in the south of the county, if you need to go to hospital, if you go to A&E, you're going across the border. Borders shouldn't really be that important in this day and age, should they? But they really are. So you go into another borough. But there are very good communications. The professionals know each other. But one of the things that doesn't happen, that Robert has already highlighted from the previous review, is that mental health professionals, the liaison psychiatrists based in that hospital, don't have direct access to the mental health records held in Buckinghamshire. So for people who present over the border with mental health needs, how do we know that the assessment of their mental health has really taken into account everything we know about them? So what we know is the liaison psychiatrist who saw adult Q in that hospital said, basically, seems fine to me. Don't need to worry about his mental health. This is about his physical health. No, we don't need a mental health fact assessment. And now I think everything's fine. What we don't know, it's still an unanswered question, is that if he had been reviewed by mental health professionals who knew him in Buckinghamshire, would their assessment have been the same? We don't know. So it is a real unanswered question. Self-neglect pathway. You're going to hear later on this afternoon about the self-neglect toolkit within Buckinghamshire. So this is part of implementing these recommendations. So again, it's looking at self-neglect. What are the options? What do we do? If you are working with someone who appears to be self-neglecting, they're not looking after themselves well, what do we do? As practitioners on the ground, what are my options? So you'll hear later about that self-neglect toolkit. Safeguarding responses to allegations. As I've said, the context here is about Ms. Y and the allegation about financial issues and possible financial abuse. But who was doing that safeguarding inquiry, that Section 42 inquiry? Had they really thought about the impact of that? Had they thought what it would be like for adult Q not to be having contact with Ms. Y, or what it felt like for Ms. Y to be having a serious allegation made against her for someone she considered to be a family member, and what was she supposed to do in the meantime? Could that have been done better? Had we identified Ms. Y as an informal carer? We knew she was managing his money, we knew she had lots of contact with him, but are we good at identifying carers who aren't family members? Possibly not. So we're pretty good at identifying carers, and a lot of work's been done locally. There's a lot of really positive carers work going on to undertake assessments of carers' needs, but also to provide informal advice and support. But in order for carers to access that, they need to be identified as carers. Professionals need to have said, have you thought you're in a caring role? You're not just helping out. You're not just doing what anyone else would do, which is often what we hear. You are a carer. It's a funny term, and it can sometimes be a barrier, but we do need to get around that to ensure that they get the advice and support that they need. Have we got time for questions? I'm not sure how I'm doing for time. 5 minutes. Any questions? About adult Q? Or about adult T, actually, if Robert's happy to answer them. Silence. I'll take that as a positive silence. Oh, no, sorry. They were raising concerns that adult Q was neglecting himself, but one of the issues was that wasn't necessarily seen as a safeguarding issue. It was an issue about care delivery.
Making these referrals, but we've seen that they're silly referrals, if you like, whether it be on neglect or anything. So for me, knowing that what involvement he had from all these people, it seems like there's nobody really. It was just a case that the care agencies were put in to do these visits, and nobody was reviewing it. And where was the social worker, if there was one allocated, reviewing his care package? So for us as an agency, you know, lots of customers with all different needs, all different individual-based care plans, but it seemed that his care plan wasn't reflecting perhaps what he needed or the support that he needed, and nobody, the agency not following it up, or someone
Yeah. My understanding is that the agency were highlighting the concerns. They were highlighting that when they were going around, either that he wasn't there, or that he was refusing care, or that there was no food in the house, and that the house was in a poor state. So they were highlighting that. The issue we had was who was picking that up and who was doing something with it, and why that was. Because we then had adult social care and the community mental health team working together, seeing adult Q on a daily basis from the mental health team's perspective. But who was picking up actually how are we meeting his needs going forward? And that certainly on discharge from the admission, that the coordination was completely lacking. My understanding is the care agency also weren't restarted.
came out of hospital. I presume that a call was made to reinstate his care.
No, my understanding is not. You'll have to forgive me because I'm not the author of the report, but my understanding is not that there was poor discharge planning. But that feedback loop, we've heard about the importance of the feedback loop following requests for referrals for Mental Health Act assessments, but I think it works for raising of safeguarding concerns as well. If you've raised a safeguarding concern, by the very nature of that, you're worried. That's why you've raised the safeguarding concern.
We find now that when any of our customers go to hospital, if we are proactive now in ringing hospitals and informing them that this person has a care package, so before they are discharged from hospital, they have to contact the agencies. And if, you know, following it up is good practice, and that's what we're having to do more and more when anyone's going to hospital. They may be in for 6 weeks and then get discharged, and nobody has communicated that. And it's that assumption that that person will get home because they have the capacity to ring us.
Yeah, very similar circumstances. But in this case, no, that's my understanding.
What's the time frame from delivery
think it was 9 days. It was less than 2 weeks. So a relatively short period of time. And certainly, as I said, one of the key issues that stands out for me is that discharge letter that went from the hospital to the GP hadn't got to them before then. I don't think it was completed before he died. I think it was still... Okay. So that's another issue of feedback loop. Yes, the safeguard inquiry is concluded, but the person, Ms. Y, who the allegations were made about, wasn't given that feedback. So one of the impact there is that, okay, no concerns as far as safeguarding were concerned, but Ms. Y, as far as she's aware, is still at arm's length, has still stepped away from her supportive role. Okay. Thank you.
To say thank you to Robert and Mary, because they've actually set the scene of all of the themes and issues that will be dealt with during the course of the remainder of the day. It's now coffee time. Could I ask that everyone would be back promptly for 11:20, because there are other speakers to go. Thank you very much.